All right, we're going to go ahead and get started. Hello, everybody. Welcome to North Shore Pediatric Therapy's webinar on ADHD from start to finish, as presented by Dr. Greg Stasi and Dr. Cynthia Kane. Dr. Greg Stasi is the Director of Neuropsychology here at North Shore Pediatric Therapy, and Dr. Cynthia Kane is one of our esteemed neuropsychologists. They're going to be going over the basics of ADHD, including what it is, what it isn't, how it's diagnosed, how it's treated, and how we can manage it during the COVID-19 pandemic. So, without further ado, I'm going to hand this over to Dr. Stasi.
Thank you, Nikki. So the first we're going to talk about what is ADHD. It's a persistent pattern of inattention and or hyperactivity and impulsivity. It interferes with functioning or development. And that's something that's going to be really important, is that just because the child might have inattention or hyperactivity, there has to be an impairment in either the child's academic functioning or social functioning.
So inattention can look like several different kinds of things. Wandering off task, lacking persistence in tasks, having difficulty sustaining focus, being disorganized. Some things that you may notice in kids that are inattentive is difficulty with getting through daily routines. So if you feel like, it's not a surprise that I'm springing on you that when you wake up, you brush your teeth, you make your bed, you get dressed, but yet every day you feel like you have to walk them through the same instructions, that can be inattention. Daydreaming, losing things, those can also be signs of inattention.
Hyperactivity is excessive motor activity when not appropriate. You see the child who's excessively fidgeting, tapping, talking. Leisure time is really hard for this kid, that they're kind of want to be on the go always. They interrupt often. Sitting down, watching a movie, or just eating dinner is often hard.
Children that are impulsive often lack a desire. They have a desire for more immediate rewards, so they have an ability to delay gratification. They often have hasty actions that occur in the moment without thought, so it's sort of like reactivity, just acting without thinking. Oftentimes with this, you can ask a kid, why did you do that? And they'll say things like, my brain made me do it, or my body just did it, but they genuinely can't not do certain things.
ADHD, in order to make the diagnosis, it technically has to begin in childhood. The DSM-5 indicates that the symptoms must be present before age 12. Now, one of the concerns, though, as an adult, it's pretty hard to recall a lot of memories before age 12. So there is some ambiguity about diagnosing adults with ADHD if we don't have records of their childhood.
When can ADHD be diagnosed? We get asked this question a lot, like, is there an age that's too young? Do they have to be in school first? Most children we see are school age, so age 6 and above, but research does indicate that children as young as 4 years old can be diagnosed. It is helpful when they're school age, because then you have another platform, like another data point where you can see how they're performing. So not just at home, not just in a testing setting, but also at school.
The symptoms of ADHD must be exhibited across multiple settings. So that can include school, work, home, the clinic. If it just happens in school or just happens in home, that's going to be probably more environmental than organic attention or impulse control issues.
ADHD occurs in most countries at the same rate, with 5% of children being diagnosed and 2.5% of adults.
ADHD is more frequent in males than females. In children, it's 2 to 1. For every 2 males, 1 female will have the diagnosis. In adults, it's 1.6 to 1. With females, they're more likely to present with inattention than hyperactivity. What we also know is that males are identified more times than not at a younger age than females, because they're the child that's impulsive, hyperactive, and they give the teacher a lot of grief, right? That they're the kid that's constantly out of their seat, blurting answers out, whereas the girls are more likely to be distracted internally.
So there's a common misconception that there's ADD and there's ADHD, and they're 2 different things, and one has hyperactivity and one doesn't, when in reality they're all called ADHD. It's just that there's different subtypes. So predominantly inattentive presentation, those are the kids that have difficulty with focus, staying organized. They're the daydreamers. Predominantly hyperactive impulsive presentation is more of the stereotype that people think of, like, circle time in preschool, all the children are sitting on the rug except for the one kid who's climbing the bookcase. And then combined presentation is a combination of a little of column A, a little of column B, where they may have difficulties with focus and executive functioning, but they also have some impulsivity and hyperactivity.
What it is not. We're going to go over each one of these briefly: the Feingold diet, food additives, and then too much television. Benjamin Feingold was an allergist. In 1973, he posited a claim that over half of all children who are hyperactive got that way from eating foods that contained additives and preservatives. There has been no evidence to ever provide that consuming such substances increase the risk of ADHD. It also shows that such additives do not increase hyperactivity in children who already have a diagnosis of ADHD. Diet modification is not effective for treating hyperactivity. Not a single study has shown that sugar is a major cause of ADHD. Sugar could cause momentary increase in hyperactivity and impulsivity, but it doesn't cause the hyperactivity and impulsivity that we see in the children who have the diagnosis. There's another therapy, it used to be common, called megavitamin therapy, where we could give the children large doses of magnesium and zinc. No study has ever shown that large doses of these vitamins helps children with ADHD.
We're often asked about the impact of screen time and television. No studies have shown that television viewing causes inattention or causes hyperactivity. No studies have shown that children with ADHD watch more television than children who do not have ADHD.
So in order to get the evaluation for a child for ADHD, it can be done through several ways: the pediatrician, psychiatrist, psychologist, and neuropsychologist. The physician will often get collateral data. They'll get rating forms from the parents and the teachers. Psychiatrists will likely do the same, and then psychologists, neuropsychologists will do more formal evaluation and testing.
So on our end, a neuropsychological testing situation would involve a comprehensive evaluation where we're looking at multiple domains of functioning. So we're looking at cognitive functioning, which is what you think of as IQ. We look at academic achievement. We look at attention and executive functioning, and then social, emotional, and behavioral functioning. So we want to get information from multiple sources. We're looking at how they're doing in clinic. We're looking at the interview information that we gather on clinical interview. Feedback from teachers is often helpful, from therapists, because we want to see the frequency, the severity, the duration of all of the behaviors that are being reported.
Treatment of ADHD often is thought of being along a team approach. You might have a physician, be it the pediatrician or psychiatrist, that might prescribe medication, a therapist to either work with the child or the family to help behavioral strategies or teaching what's known as executive functioning skills, such as organization, time management, task initiation, and then school accommodations.
Pharmacological intervention is another major component. Studies have shown that the #1 intervention for ADHD is a combination of pharmacological intervention and behavioral therapy. We know that, you can't just give a child medication and hope that their behavior is going to change. They also need to learn some behavioral strategies to self-regulate. And on the flip side, we also know that you could teach all the behavioral strategies in the world, but there is a neurochemical component to ADHD that may require pharmacological intervention. There are two kinds of medication that are typically used in ADHD. There's stimulant medications and non-stimulant medications. Do you want to talk more in detail about those, Greg, or no?
So stimulant medication is the traditional medication that's used for the treatment of ADHD. Studies show that it's efficacious and it works at its prime in about 75% of children who have ADHD. Your stimulant medications, there's two main classes: methylphenidate-based drugs, and that's going to be Ritalin, for example, and then you have amphetamine-based salts, which are going to be Vyvanse or Focalin or Adderall. Your side effects for stimulant medications, your main ones you might say are going to be appetite suppression, some sleep onset difficulties, and a mild headache. Non-stimulant medication, Strattera is the main one that is utilized by physicians. Strattera takes about 4 to 6 weeks to work, and the child has to take it every day. And the efficacy is not as strong as your stimulants. Therapy. So there's two main types of therapy that are often utilized for a child who has ADHD: social work support or psychological support, and that's going to be working on behavioral modification to help improve on-task behaviors. The therapist will often work with the parents to develop reinforcement schedules to get the child to do what we want him or her to do. And in occupational therapy, these are going to be working on strategies to help with self-regulation. They also will work on executive functioning skills. Again, that's going to be the organization, your task initiation.
School accommodation. So this is tricky because school is kind of a hypothetical thing right now. But when school was an actual thing and kids were in the classroom, kids with ADHD benefit from a 504 plan, which would be accommodations in the classroom, which is usually accommodations or adjustments to their classroom day, to the format of the classroom. So like seating them at the front of the class, checking in with them, giving them extended time if they need it. An individualized education plan, an IEP, is when a service is required. So this would be if they needed to work with a resource teacher, or they needed speech and language therapy services, a social worker. So really depending on what your child is presenting with, the determination would be made which is more appropriate, a 504 plan or an IEP.
One of the big questions we get all the time now is this ADHD or is this just my child dealing with COVID-19? We see an increase in anger, anxiety, impulse control. We're putting children in front of a laptop where they're being their own teacher now for 8 hours, 6 hours a day. And it's often hard to kind of discern the differential out. And a lot of that for our evaluations is why we really need collateral data. We want to really talk to the family. What did things look like for this child prior to March when we were quarantined? Would get data from the teachers, past teachers, current teachers, see is there discrepancy between how the child's performing in Zoom meetings versus when he or she was in the classroom. Looking at previous report cards, is the teacher's reporting the child has trouble sitting still in the past, or is this all new behaviors, right? If it's newer behaviors that are since March, we're probably not going to say, we still want to address it, but it might not be consistent with what we expect for a child with ADHD. We often hear, is it lack of engagement because they have ADHD, or is he just lazy and unmotivated? When we're talking about motivation, and a lot of times with ADHD, we have a child that can sit and play video games for 5 hours straight, right? But sitting down and reading a book or doing their math homework is really pulling teeth. And that's part and parcel of the diagnosis, is that it's often an issue of a lack of inattention to non-preferred tasks. So we try to stay away from terms like lazy, unmotivated, and that Johnny may appear that way, but it's really because he really struggles with zoning in on these non-preferred activities. Treatment of ADHD during this time, that's the million-dollar question. A lot is going to be that we can still talk about the pharmacological intervention, getting the child on a medication to help with the attention, the impulse control. A lot of therapy is being done by Zoom or telehealth right now, so we at least you can get some support that way. But the hardest one that we're finding is school accommodations. We can get extra time, but how's it implemented right now, right? A lot of times parents and grandparents or a babysitter is going to be forced to be in the role of a teacher now. And it's hard to kind of input some of these 504 accommodations for children. Now, so that was ADHD in the synopsis. Now we want to spend some time with questions and answers that you guys may have.
Alrighty, so as I said at the beginning of this presentation, if you guys have any questions from that presentation, there should be a Q&A button at the very bottom of your screen. Go ahead, click that. You should be able to submit a question that way. In the meantime, we did get a couple of survey questions that I thought that the doctors could answer for us. So let's go ahead and start with this. Since we're already talking about COVID-19 and the impact that it's had on all of our lives, what routines do you guys recommend for children with ADHD during the pandemic, whether it be a school routine or a home routine or something to just help them manage and cope with ADHD while they're stuck indoors?
Sure. A lot of the routine and structure are going to be critical. We want to have things as structured as possible. Just having the child's schedule written out in front of them for the Zoom meetings that are setting timers on either Alexa or on their iPad if they're using it for when they have another Zoom meeting, when their break's over. We really like to keep things as organized, as structured as possible in general.
Thank you so much. So we have a question from one of our attendees. She says, or he says, I'm sorry if I got your pronouns wrong. I received a list of about 15 therapists that are within my network for behavioral therapy. How do I know how to choose among them?
Great question. I think it's going to be a little legwork on your part. What I would recommend doing is looking at the therapist online, go to their websites, seeing what their background looks like. Do they have training in ADHD? Give them a call, right? And just ask, how do you guys work with a child with ADHD? Because with therapy for a child who has ADHD, a lot of the behaviors are going to be working with the parents, right? So I just don't want you guys to drop your kid off in the therapist's office, come home every week and expect miracles. It really should be working with you guys as much as the child, teaching you strategies on how do we organize, how do we modify the environment for a child.
Well, thank you very much. I'm seeing a lot of questions regarding medication, so I'll go ahead and ask a question that we actually got from our survey that might get us rolling on this. Under what circumstances do you find medication appropriate for a child?
So I'll take that one. It's appropriate if you've tried things, and we often have situations where parents are like, you know what, we've tried behavioral intervention, we're very structured, we're very consistent, there are services in place, you know, we've done everything kind of by the book, and it still doesn't seem to permeate. The strategies aren't working, they're not able to access them. When it's functioning, when it's affecting your functioning, so whether it's affecting them academically or socially, emotionally at home, at that point, if what you've been doing behaviorally hasn't done the job, then medication is probably the component that's missing.
To follow up on that question, I actually got a really great question from somebody. Is there an age that's too young to start medication?
No, I mean, it's really going to be the impact that the behaviors have on the child's functioning. So if we can get therapy, get some school accommodations going, and that's enough, that's great. But if there's severe impact of the child's ability to learn, severe impact of the child's socialization, then it's probably appropriate to talk to the physician about it. And oftentimes we will punt that question to either the pediatrician or psychiatrist who might prescribe the medication.
Thank you very much for that. I just found a really good question. I'm trying to see it and see if I can find it again. In the meantime, how do you distinguish between ADHD and just typical run-of-the-mill hyperactivity and distractibility?
Sure. So it all goes down to the extent that either the impulsivity, the hyperactivity, the attention has a significant impact on the child's functioning, right? If the child might be a little distracted, but still able to keep up in school, still able to keep up socially, it might not be something that we really want to deal with, right? When an issue becomes an issue is when it has an impact on the child's life.
Thank you very much. To follow up on that, when do we hold our children accountable for their hyperactivity, and when do we basically chalk it up to the ADHD? Is there an appropriate way to figure out how to discipline your child while also being graceful with them?
I think setting expectations is a fair way to do that. So I think, you know, if you're straightforward with your child, like, we know that you struggle with this, we're going to try and help you with it, but these are our expectations. If you do this, this will happen. If you do that, that will happen. Then you're sort of setting up, you know, you're not throwing any curveballs at them. You're not expecting things from them that are not realistic.
So to ask another question from the chat, if I'm a parent and I'm waiting on an eval, but I still want to address my child's behavioral issues in the meantime, should I go ahead and enroll them in therapy, or should I wait on the evaluation, even if it is several months?
My recommendation is to get the therapy going as soon as possible. Just getting some behavioral strategies in place can help out significantly. It might be one that, you know what, when we get the evaluation going, get the input from the psychologist, you might modify the therapy, you might change things up, but right now it'd be a good idea just to get the process going.
So if we can switch gears a little bit back to medication for a moment, one attendee asked, my son is on, and I'm so sorry if I pronounce this wrong, methylphenidate. Thank you very much, Dr. Kane. How can I assess if it's still working or if an adjustment is needed? What are some things that I can watch out for?
Sure. If we were in school, or if your child's in the school day, the biggest recommendation would be get the teacher to send you an email every day about how was the morning and how was the afternoon for a good couple weeks, right? And we could see the morning was great, afternoon was falling apart. Okay, we want to up it a little bit more. But unfortunately, we're not in that situation. So a lot is going to be, as the parent, behavior observation, seeing how does the child look like they're performing in the morning on their Zoom meetings. Do they start to get a little hairy in the afternoon? And it might be then that we will need to boost it up a little bit more. Some things to look out for is the child, it shouldn't happen, but a small percentage of the children can get more somewhat irritable, frustrated, more angry. And that usually happens around 3 or 4 in the afternoon when medication's like weaning out. So look for any changes in personality, anything that looks different from your child. The way that I like to think about medication for ADHD is that the kid is the same goofball that you guys know and love, but just more attentive and focused. It shouldn't make them zombie-ish or doped out or anything.
All right, to follow up with another more specific medication question, what is the difference between Ritalin and Adderall when it comes to children under 10? What should I look for?
Well, they're both stimulant medications. That one I'm going to punt to the treating physician because they'd be the psychiatrist or a pediatrician who would prescribe. And the research indicates that there really is no major differential to which one do we need to give to a kid based on age. Do we need to start with Ritalin or Adderall? The only reason why you would want to start with a specific medication is if a immediate family member, so parent, sibling, was on one of the medications and it's working for them, then you're probably going to want to try the same one from a genetic component.
All right, to follow up with another question about medication, what are the indicators that a child needs treatment with non-stimulants versus stimulants?
So usually you'll try with the stimulants first. Stimulant medications are quick acting. So they're in the system within 45 minutes. They're out of your system within 8 to 12 hours completely. Why you would want to start with a non-stimulant? Usually the doctor will want to start with a stimulant first. And if the child cannot tolerate it, there's side effects that they just can't handle. They have headaches, irritability. Then you probably want to go to the non-stimulant.
All right, if we can go ahead and switch gears for a second. We got a couple of questions about diagnoses and how they play with each other, for lack of a better term. One attendee asks, sorry, just a moment. Would ADHD be treated differently for kids on the autism spectrum? How young can a child be to be treated with medication, which we already answered before?
So oftentimes when we're talking autism and ADHD, we see ADHD characteristics in children with autism. Are they two separate diagnoses? That's really hard to discuss or figure out, right? But oftentimes you might want to treat the inattention, the impulse control, and the hyperactivity as if it was separate ADHD. And again, for that one, I would really punt that to psychiatry to really answer that question of how they want to handle that.
To follow up with another question about different diagnoses, can you explain the interplay between a co-diagnosis of ADHD and anxiety?
It's fairly common that kids are diagnosed with both. Sometimes the anxiety is related directly to the ADHD and that they're aware that they're struggling in a certain area. It's sort of like a chicken and egg thing. One doesn't really cause the other, but there is an interplay between the two.
Alrighty, so to shift gears back to just general questions about ADHD and how to live with it in our daily lives, what role do routines, exercise, and diet play in ADHD? I know that we talked a little bit during the presentation as to how diets don't cause ADHD, but are there perhaps diets that can improve ADHD?
From a research standpoint, not really. It's all moderation. It's all having a healthy diet. So there's really putting a child on a specific, like a gluten-free, casein-free diet from a research standpoint isn't going to change the attention, the impulse control at a significant level. Exercise is good as well. Is it going to significantly improve? Probably not. Structure and routine, those are all critical as well. So just having organization, having daily structures of anything from bedtime routine to what do we do to get out the door to starting our homework is all critical for these children.
All right, it seems like we've got a couple more questions about different diagnoses and how they play with each other. Can you explain the interplay between dyslexia and ADHD?
So sometimes what we see happening is like if you think about it in terms of a child who's in kindergarten, and that's when they're learning phonics and the building blocks of reading, and they have ADHD. And so if a typical kindergartner, if we're being generous and saying that they're paying attention like 80% of the time, but your child has ADHD and is only getting like 60% of that, the class is moving forward and your child is still trying to play catch up because they haven't really been attending. And then on top of that, if you have, a predisposition to difficulty with reading, like difficulty with phonological processing, you're going to see the comorbid diagnosis where you're going to see the reading disorder and the ADHD.
All right, in teens, how do I know how much of the moodiness and frustration is due to the ADHD medication side effects and how much of it is attributed to just being a teen?
I guess the answer to that would be, do you see an increase in the moodiness since the medication started? If you take a weekend off with the medication, if you're doing a stimulant, does the moodiness go away or lessen to a degree? So it's really a kind of single subject design to see, are there changes since the medication was implemented? We take away medication. If the moodiness goes away, then okay, that might be irritability that's associated with a side effect. Or if it's still there, then okay, just probably a secondary being a teenager.
So we have time for one more question. I'll wrap it up with this. My child scores high on standardized tests and earns good grades in school, but this is partly because the concepts in school come in quickly to him and he gets a lot of parental support. It's diagnosing high-achieving children with ADHD complicated.
To some degree, kids that are very intelligent can use compensatory strategies better, and it may be a little bit difficult, but no, I wouldn't say that it's more difficult to diagnose because it manifests in other ways. So maybe they're doing well in school, they're doing well academically, but they have difficulties at home or difficulties socially. So no, I wouldn't say that it's more difficult to diagnose in an intelligent child.
All right, that is all the time that we have. Thank you so much to our doctors for this lovely presentation and for answering these questions. And thank you to everybody who decided to attend. If you want to know more about our services, you can visit kidsblossom.com. You can follow us on Facebook and Instagram at NSPT4Kids. And if you want to ask a question that perhaps we didn't get to during this presentation directly to one of our neuropsychologists, you can email askneuro@kidsblossom.com. Also, if you're interested in getting an evaluation or knowing if your if it's appropriate for you to pursue an evaluation right now, you can request a free 15-minute consult with one of our neuropsychologists. You can find that form at northshorepediatrictherapy.com/neuropsychology-consultation. And if you tune into our Facebook, our Instagram, or if you're enrolled in services with us, you will be informed of our next webinar, which will be covering learning disabilities. We hope that you can come to that if anything here interested you. But in the meantime, have a fantastic day, everybody. And thank you so much again for joining us.